That was important.
Yeah. How things are, like,
And you're definitely unmuted.
yes.
We should be able to take it.
You want to do the Q and the polls? It's this right here. Click right here.
Okay.
All right.
Yeah. All right. Well, good morning, everyone. So thank you, Jason. So good morning, everyone. This is a multitasking Grand Rounds. It's going to be more interactive than usual. And we have actually multiple goals that you wouldn't think are all wrapped in together, but hopefully by the end of it, we will be in a better place than we were before. And I'm hoping. We'll start off by saying that this is usually the chair's update, sort of like the status of the department. In this case, I am going to do a little bit of that, but more towards the end, we're going to talk about our strategic plan, or our rapidly developing strategic plan, as well as hoping to get your input on several of our new initiatives. So with that, I'm going to go ahead and start. You can see the title, Artificial Intelligence in Medicine. Is it going to help us or just replace us? Just a little bit of background, and I've got a lot of slides to do in a little bit, in 13 minutes less than I had before, but we're going to try to get through it because at the end, I'm hoping that everyone will actually write down your question and see.
This is what the audience is saying.
Okay.
Not that, so.
I see. That isn't, yeah, that's not presentation mode.
Mm-hmm.
Okay. So actually, so Jason, can you take a look? So probably best to just,
Okay.
it's actually which screen they're looking at. They're looking at mine instead of the,
Right.
still. Okay, yep, we're good. Okay, all right. So I've been known for presenting quickly. This is now going to be at racing speed. But by way of introduction, what is it that we're talking about with artificial intelligence? It's basically taking a computer program and allowing a machine to perform cognitive functions that we normally associate with human abilities, such as perceiving, reasoning, learning, interacting with the environment, problem solving, and even being creative. AI technology can actually process way more data than a human can, 30 million times, in fact. And the goal of AI is to actually help us by recognizing patterns, helping make decisions, and even ultimately to make judgments. It's actually, can't really do justice talking about AI in the presence of medicine only, because it affects everything, such as markets and banking and education. In terms of technology, you'll see a lot of products out there, and you've actually been subject to this for a while. The moment Amazon got big by sending you, recognizing what your patterns were, and sending you advertisements for the things that you were interested in, that really was the beginning of commercialization of it. But it's now moved to things like the autonomous vehicles with Tesla. So who's the market leader here? I would say at this point, ChatGPT. And how did OpenAI sort of take over when there's so many great products out there, including, I should mention, Bard probably has the best capability because it actually is real-time web. So if I publish something yesterday, which I actually did, and I'm going to show that to you, it already has it, and it'll incorporate it very quickly, whereas the rest are still searching. But ChatGPT made a big move, which is last November, to make it free. So how many of you have actually used ChatGPT? Almost half of you. Okay, so but everyone else, you will be using it probably by the end of it. Hopefully, you'll be convinced. Okay, so let's go. we're educators, and so you have to know that this really is dramatically changing education. For example, you really can't ask people to do essays anymore, and even theses. And as a journal editor, everyone's worried that you're going to have all this automated intelligence writing papers. And I can tell you, as a journal editor, I'm more concerned about the content and the accuracy than who wrote it. And I know the chat box isn't going to get a promotion based on it, but the person will. I'm really interested in disseminating the latest and greatest information, and so I'm not bothered by it. But some high school teachers really want to know that a person can write, and so there are some problems. However, on the plus side, being able to have a teacher spend more time talking about cognitive improvements and better decisions, and doing some automation of menial type of tasks that they don't like grading and data analysis, is really allowing them to focus on higher level tasks, and that's great. In medicine, it's really developing very quickly. We can automate some routine tasks and spend our time taking care of the patients, actually spending our time doing more complex and value-added tasks. We should be able to use AI to more accurately diagnose, reduce costs, improve quality, efficiency, documentation should improve, patient outcomes. And hopefully down the road, we're going to prevent some hospitalization, some illness, and some reduced mortality. Now, there are people out there saying that it's only a matter of time before humans are completely replaced in certain roles within the medical community. And the three big topics tend to be around imaging, where you can take a picture of something and have a machine learning try to figure out how to get to the final answer faster than a human can. And so that's basically radiology, cardiology, pathology. And you'll see this whole idea that, and you'll see it all over the internet, don't let your kids go into radiology because they're going to be replaced pretty soon, or make all your income and put it away. Don't spend any of it. Maybe that's a little overblown, but it can be seen as either a threat or an aid, depending on how you look at it. This is computer-aided diagnosis of chest X-rays. When you look at really carefully done studies, the AI actually does do better than humans. It doesn't miss much. And it's starting to get to the point where it not just recognizes patterns, but continues to learn. And that machine learning means that it's always and not going to forget anything, and it's going to get better and better at being able to localize abnormalities. And so, maybe this is a little premature, but it's something that has to be considered for anyone who's doing imaging. When we look at probably the biggest area for cardiology is the echo measurement of ventricular function using strain imaging, which is basically displacement of the myocytes. And you can actually get really good data. Okay. Where a video stream can be with a series of analyses through the network, you can actually come up with exactly what the heart is doing and get that strain pattern that'll actually give you good amount of information about ventricular function, and certain patterns such as amyloid heart disease, where the apex has really good strain and the rest of the heart has less. That particular pattern would be picked up easily by artificial intelligence. How reproducible is it? How accurate is it? All the data looks like it's really good. And so it should be something that we don't labor as much with anymore. That's one way to look at it. Okay. How about pathology? Cytopathology shown here with an H&E stain on the left and fluorescent imaging on the right. Well, you can how much of this is tumor and how much of it isn't. If you use a very wise pathologist, they can mark it for you pretty well, and it correlates, but it's not exactly what you would get from the patch sampling with computers. So you could take past specimens from beginning to end, okay, and have the AI improve your quality control, improve your diagnoses, and actually do all the tasks like making a report, setting it up for multidisciplinary board review. And so this really is seen by some as a threat to pathology, and I'll return to that at the end. But let's talk about medicine. And so some of you may have seen that there's a series in the New England Journal of Medicine talking specifically about the benefits, limitations, and risk of GPT-4 as a chat box for medicine. And it's in a way comical, but it really is trying to get into the fact that you've got some limitations and you've got some real advantages. Having a wealth of knowledge means that you can analyze things, but you can detect drug interactions and identify high-risk patients, and doing medical notes, not just doing the note, but coding the note, billing, all of those things could actually be done. And so this is one of the figures from that particular manuscript, and I'm going to just run through it with you. The human is having a conversation with ChatGPT, and the question is, what is metformin? And GPT-4 does a great job talking about blood sugar levels, immediate release, what are the issues, lactic acidosis, how does it work, decreasing the amount of glucose produced by the liver, etc. And human, can anyone take this particular drug? And good answer, not necessarily appropriate for everyone. If you have kidney dysfunction, more likely to get that lactic acidosis. Talk to your doctor, always saying the right thing. What other options are there? And that's where it breaks down. Sometimes you just get errors, and sometimes you just get what's called hallucinations by AI. And so everyone looking at this answer is smiling, because at least all the cardiologists are, because there are two diabetes drugs that are better than anything we've ever had in cardiology, and that's SGLT2 and GLP-1, and they're just missing from the list. If we go, there we go. So the human then says, gosh, that's really complicated. I don't know if this is right for me. And GPT says the right thing. Talk to your doctor, talk about all your concerns and your history, and figure out what you don't have to do this on your own. Great. And then the question is, how did you learn so much about metformin? Well, I have a master's in public health and volunteer in a diabetes nonprofits and have personal experience with type 2 diabetes. And the human goes, what are you talking about? Okay. You never received a master's in public health. And that, as you can see, just messing around trying to sound impressive, I looked it up on Google like anyone else. And so that would have been a hallucination and a little comical. But notice block C here. You could ask the GPT to validate the output of GPT. And if you do this, and those of you, the half of you who have done this already, you know that if you ask the same question twice, you don't get the same answer. And that's why it's so difficult for people with essays or trying to detect that somebody used the chat box, because all of the language is it really is generated on the fly. And GPT actually criticizes itself. AI-powered chatbots do not have personal experiences and education backgrounds. Okay, so that was actually really good. Okay, so this is the part that I was hoping to get to. So where do I think we could do something in medicine in our department? Well, I think there's two phases to it. One is, with the use of our EHR, we could actually get to the point where all of the things that I'm going to show you 8 different things. Where did I get them? From our notes. There are things that are in guidelines that I've co-authored, and I'm calling them clinical opportunities. You can call them guideline gaps if you want, but I find that pejorative. So they're clinical opportunities. And what I'm hoping to do is convince all of us to have each other's back. And I should actually send you, and sometimes I do send the note with very particular statements. Uh-oh, Jason, did I lose everybody or just? Okay, we're back. Okay. So if I see something that doesn't go with the guidelines, and if you see something that our colleagues are doing that doesn't fit with the guideline, I'm inviting you all to just send a note, have each other's back, okay? Because crowdsourcing may not be as good as AI, but it's better than us as individuals, okay? And so I want to talk about that. I'm going to give you 8 different scenarios, 2 different slides, each with 4, and just pick out the best evidence clinical practice. Okay, so this is where I start the poll. Everybody's read through them. It's about 30 versus 90 days for blood pressure pills, home blood pressures versus office blood pressures, aspirin for primary prevention, and plant-based diets. I couldn't give you a talk without talking about plant-based diet. It's not going to happen. Okay. Better for cardiorenal risk, but not so much for GI. And I'm sorry for the gastroenterologists who were at the Nestle lecture last week, because some of that's reproduced here. Okay. So I start the poll. Launch. Okay. And everyone is logged in. Helen, am I doing? It's launch. There you go. Getting some answers. Okay, I'm going to give it 10 more seconds, or actually, I guess 5 more. That'd be a total of 30 seconds. So I was allowed 30 seconds per slot in order to get through this talk. All right. Okay, it's slowing down a little bit. Okay, so so a little bit of traction for 30 days versus 90 days, the home blood pressure records, that is the majority of people are saying that one is the correct answer. Aspirin for primary prevention, a handful, and plant-based diet, better for cardiorenal but not for GI. Okay, thank you for that. And so let's see, what does, so I don't really want to share it. I'm just going to stop sharing. Okay. Just exit. Yep, thank you. Okay, so what does ChatGPT say about them? Okay, so 30 days versus 90. ChatGPT actually goes through this saying that there's some advantages to 30-day prescription, flexibility monitoring, cost and travel. For 90 days, more convenience, more cost savings, more medication adherence, okay, and reduced hassle. What it didn't quite pick up is that there actually is evidence on this that was published not that long ago, talking specifically about adherence. And maybe there are those of us practicing in areas where adherence is not an issue. But since so many of us are working with our socioeconomically deprived people, we really do need this adherence. And so I know Dr. Kruger has heard me go about this over and over again, that our default in Epic should be 90 days, and it should be 4 refills, so that we have a full year, not 360, but over 365. And so we actually can do that, and I would hope that that becomes our standard. Okay, home blood pressures correlate with outcomes better than office blood pressures. They did a pretty good job. White coat syndrome, multiple measurements at home, more familiar environment, not so much with the rushed appointments. Understanding the white coat effect, that's a little bit of a hallucination because it already talked about that and did it twice. Lifestyle factors, really important. Regular monitoring, which is really important. Increasing patient involvement. I like putting those two together. And it gives a good sort of summary that office blood pressures are limited compared to home blood pressures. What it didn't quite pick up was the fact that there's good evidence coming from Ireland a long time ago that showed that the conventional office blood pressures are the worst blood pressures that we have. And so I do see our notes where the patient is being given antihypertensive therapy, but hasn't been told, you must bring me back. I'm not telling you your blood pressure anymore. You tell me your blood pressure. Bring back lists and lists and lists of your blood pressures, because they correlate with outcomes, the 5-year risk of death better. Well, if it's some kind of home blood pressure done in the daytime, 24-hour, nocturnal, even the best, those correlate with predicting cardiovascular death. And so that actually is in our guideline. The other one that people don't talk about is masked hypertension. What is that? It's where people have normal office readings, but they're actually should be on therapy because their home blood pressures are high. Sometimes it's a sad social situation, living in an area where there's fear or abuse of an elderly person. But it's really important to know what those home blood pressures are, and that could start a conversation with the patient, their family, the social worker, whatever it takes. But you also know that that patient is at risk. Okay, how about aspirin? So I still see notes from the way, problem with cardiology is that everything changes. A few years ago, we were really big on doing aspirin for primary prevention. And it turns out that, okay, all right. Okay. that it's something that really needs to be discussed because the data has from multiple trials, particularly giving it for diabetics, turns out that that wasn't a good idea. It resulted in a fair amount of GI bleeding. And it's something that we should be only considering if a person really has disease or extremely high risk. And so we want to try and make sure that we're separating primary and secondary prevention. That is, someone with known disease, they've had a heart attack, the antiplatelet therapy is very helpful, but giving it for primary prevention is something that we try not to do because of that bleeding risk. And so when you talk about age and gender, older individuals, it turns out that was specifically one of the trials that looked at this and was shown in a randomized long-term outcome fashion to show no benefit for aspirin and just more bleeding. And so these guidelines will change again. For example, we don't use as much aspirin as we use the other three, Brilinta, prasugrel, and clopidogrel, because they are safer and have less events than aspirin. So aspirin's on its way out anyway. So what our guidelines have to say about this? We really tried the hashtag Rethink Aspirin in the 2019 prevention guidelines to get people away from it. Low dose, if you really feel strongly about it because someone has a really high ASCVD risk, that becomes a to be indication, meaning to be or not to be. And making sure that we're not using it for primary prevention routinely in older people, and we're not using it in people who have increased risk of bleeding. Okay, plant-based diets and lower cardiorenal risk, but not GI conditions. Let's take a look at what ChatGPT has to say about that one. Hepatogastric GI indications or where the diet can have a big impact include non-alcoholic fatty liver disease and gallstones and hepatitis. And this one is in blue. And sorry that when you switch from a Mac to a PC, the slides all get messed up. I don't know how much time I spent making these slides perfect. Okay, so hopefully you'll get a copy. We can send them out on a PDF and they'll be perfect. I tend to put the answer in blue if I think it's a hallucination. This one is saying that celiac disease, and the answer is actually just not part of the answer, that it wasn't part of the question. That is, you can be gluten-free whether you're plant-based diet or not. Constipation, absolutely. Inflammatory bowel disease has a lot of data, and reflux, absolutely. Multiple GI conditions can be improved dramatically. But let's go back to talk about the cardiology portion of it and plant-based diet, because that's a particular interest of mine, and you've probably seen me talk incessantly about how we were able to dramatically reduce every single cardiovascular risk factor if we, other than the genetic part, if we intervene, particularly, which we've done about to start with the disparity trial that Dr. Cook mentioned in Louisville, but on the south side of Chicago, taking every risk factor, TMAO, high sensitivity C-reactive protein, LDL cholesterol, all of them dramatically improved. We can put them in our risk calculator that you all have on Epic for ASCVD.ASCVD, and it'll tell you the 10-year risk. And our African-American population is supposedly 21% higher risk of events, and we were able to reduce in a 5-week period 19% out of that 21%. Made a nice cookbook about it. Great. What is AI? I actually changed the question a little bit. Okay, if plant-based diets are associated with reduced death rates, lower the incidence of chronic disease, help sustain the planet, and reduce animal cruelty, why aren't people doing it? Okay, so we can say ask how many. I'm not going to ask because I don't want to have that word picture or that picture in my head. How many people in the room are actually doing a whole food plant-based diet? Okay, the answer from ChatGPT, I thought was actually pretty good. They talk about cultural, social, economic, psychological features, culture and traditional habits, taste and familiarity, accessibility and affordability. And that was important because yesterday, that was yesterday, I made the slide. Day before yesterday, there was an article published in JAMA talking specifically about that issue of affordability of plant-based diet. I hear that all the time. It's too expensive. It turns out it really isn't. And the data is very true. If you want to save money, go vegan. Okay, and really not junk food vegan, but whole food plant-based, the healthy stuff that doesn't have the saturated fat, sodium, and refined grains that you get in a lot of processed vegan food. Nutritional concerns, and they point out that very accurately that most of this is just not true. B12 is true. It's B12 is in the soil, in the bacteria, and if you're not eating an animal that ate the soil, then you eat the soil, or just take a B12 supplement, okay, which I think is the easiest one. But social norms and peer pressure, marketing and industry influence, which has infected all of our U.S. guidelines. A lot of the Sugar Research Foundation was called out in JAMA a few years ago about this, but you have the cattlemen's industry, the egg board, all of them making big changes to what really should be evidence-based nutrition. And then, of course, lack of education. And this is a particularly difficult area for me because it's me and my cardiology colleagues. This article that was published a few years ago said that 1% of our practicing cardiologists and 0% of our trainees felt that they had enough nutrition education in order to actually advise their patients. So this was the article that was published yesterday. Unfortunately, I talked about it a little bit when it was pre-publication, healthful versus unhealthful eating habits of physicians. This was our work at Rush and Loyola. And out of the 274 physicians, the vast majority were eating unrestricted omnivorous diet containing all of the things that are not in our guidelines: saturated fat, cholesterol, refined grains, sugar, all of which are, and sodium, all of which are known to increase mortality and morbidity. So it doesn't really look good if only 11 out of 274 are actually getting the message. So we have to do a much better job of education. And I showed this to the GI group last week. This is processed meat, which is the World Health Organization class 1 carcinogen, and eggs, which increase mortality in every study that's not published by the Egg Board. Fact of the matter is, this was at a preventive cardiology meeting. Okay, emotional attachments and convenience and time constraints. Excuse me, those are real. As is resistance to change. People do what they are comfortable doing, what they have done. So I marked their final answer in blue as a possible hallucination, because they were saying that when you look at all of the data and the associated health and environmental ethical benefits, everybody should be vegan and vegetarian, and the movements are going to take over time. Education and awareness continue to spread, and plant-based diets are just going to become the thing. I've been doing this for over 20 years. I think that's a hallucination. Okay. However, there is a little data. You may know that in New York, there is a vegan mayor who was really unhealthy, and he claims that his diabetic retinopathy was reversed by a plant-based diet. All of the obesity, hypertension, creatinine elevation, all of it went away. Wrote a book. I actually read I'm accused of only reading medical literature. I promise you I read this book before I wrote the foreword to it. But the fact of the matter is that anything associated with New York, now that he's mayor, has or getting municipal funding, has to have plant-based stuff available, and they're actually doing well with the hospital, feeding them food, feeding the people food that's going to teach them how to live instead of making them more sick. Okay, let's take a look at the second one. I'm going to launch the poll. All right, more questions that have come up from my clinic. Okay, so back at number 2 and launch. Okay, so beta blockers are a good first-line choice for systemic hypertension. Fasting lipids are preferred to non-fasting. Okay, single drug therapy preferable to multiple drugs for mild to moderate hypertension, and blood pressure goal is less than 140 over 90. Okay, as soon as that comes back up, hopefully shortly. Okay, all right. Answer, I think we've got most of the answer. So some people are, so 8% said beta blockers are good. Fasting lipids are preferred. That actually that was the plurality of answers. Single drug therapy is better than multiple drugs, and blood pressure target 140 over 90. Okay. We're going to end the poll. And will I be able to get these afterwards? Okay, all right. So I brought up each one of these again because I saw them in people's clinics notes or in their management. And I want to show you the evidence behind it. But let's first take a look at what ChatGPT has to say. First line therapy. I think it did a pretty good job if you compare with the ACC/AHA guidelines. They talk about thiazides, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. And oops, the fifth thing it actually mentioned is beta blockers. What happened to beta blockers, particularly the two that they mentioned? That is metoprolol and atenolol. Let's be very clear. Beta blockers have a huge role in cardiovascular medicine and beyond. Intention tremor, migraine headaches, aortic aneurysms, all kinds of arrhythmias, stage fright for your violin performance, all evidence-based for beta blockers. But for routine blood pressure management, particularly as solo therapy, reduces blood pressure and does not reduce stroke. And people will argue about the mechanisms of that, but it's very clear. If there are two exceptions, it's the one that is, or the two that are alpha blockers as well as beta blockers, that's labetalol and carvedilol. And there's one beta blocker that induces more nitric oxide synthase, and therefore is a vasodilator, and that's nebivolol. But other than that, I see a lot of people being managed for blood pressure with metoprolol because its name is low pressure. They named it before the science came out. Okay. How about combination therapies? It turns out that they actually do talk about it. Really important. Let's look at first of all, what our guidelines say for our 2017 hypertensive guidelines, and I'll go back to the combined therapies in a moment. You can see that there's only one guideline, and the next update of the European Society of Cardiology guidelines will probably join the rest of us in saying no more beta blockers. Calcium channel blockers are first line. And if you're African American, then you try to prioritize a diuretic. But ACEs and ARBs are really good first line therapies as well. Single drug is just returning to the single drug versus multiple drugs. It turns out I'm putting that it did a pretty good job. The light blue is just because we talked about it already. In combination therapy, it is actually a pretty good answer, but it really needs to be emphasized even more. That is, you do better with two first-line agents in low doses, below the level of which you would get a lot of side effects. And that actually has data from it. And this is from a lot of trials, data put together. You're 5 times more likely to get control of the blood pressure with 2 drugs given at low doses than you are by doing what we used to do, sort of step care, maximize this dose and then add a second one or a third one. Okay, blood pressure goal, less than 140/90. As a hot topic from a few years ago, JNC8, which was called by some people JNC ain't. You don't hear about it because they're the ones who said that the blood pressure could be 150/90 if you were over 60 years old. That was very damaging. We put together, we meaning American College of Cardiology, American Heart Association, put together 27 guidelines to get behind that. ChatGPT actually picked that up in terms of blood pressure goal, excuse me, and it gave exactly what we were talking about. Normal is 120. Above 120 is elevated. Hypertension starts at 130. Stage 2 starts at 140. And so for most people, a goal less than 130 is recommended. And if you're over 65, still, and this is the Sprint elderly trial that said that 121 was better than 136. And so they did very well reproduce our guidelines in terms of making sure that you aim for 130 or less than 130 over 80. Okay, seeing people on a monthly basis and recognizing that people with diabetes and chronic kidney disease are in high risk. Okay, how about this one got a lot of positive answers, fasting lipids. Well, it turns out we do point of care. Anyone who in HCOC, you can ask for a point of care lipids. Why do I do that on every patient? It's a teaching opportunity. That is, you find out if a person's non-fasting, what have they done in the last 24 hours? All of the alcohol, the fried food, the refined grains, the desserts, all shows up. and it shows up with the triglycerides. And so I'm giving ChatGPT blue on this first one, saying that fasting lipid profiles are good. Non-fasting lipid profiles, it did a pretty good job, but it didn't talk, except at the bottom, about evaluating and managing high levels of triglycerides. It turns out that if you look at the guidelines, we talk about assessment of risk, okay, requires a non-fasting triglyceride level. And the data is very clear, and this was published a few years ago. So the fasting should have gone away probably 5 years or more. Large population studies show that total cholesterol and HDL do not vary, and LDL and triglycerides vary slightly after eating. With a Southern diet or so-called soul food, those triglycerides can go up dramatically and give you an opportunity to present that to the patient that you would not get if you do that with a fasting specimen. So I saw in people's notes, I'm not doing the lipid testing today because the person isn't fasting. So that we should try to stop that from happening. Okay, in the last few minutes, before we open it up for the fun part, which is going to be the questions and seeing what ChatGPT does, I wanted to give sort of an update of where we are with our strategic planning. We actually had a wonderful session on August 12th. I thank you for everyone in leadership and everyone who was not in leadership who decided to come. We really appreciate it. Thank you, Ryan, for coming and giving your time. We wanted to actually come up with a document that talks about our values, purpose, goals, talks about metrics for successes, and to help us make the adjustments necessary. Took all of our input and put it into a word cloud. It looks like that. So please get the slides and you can sort of stare at it. I want to give credit and to all of our leaders, Dr. Kruger for clinical. You've heard my 5 pillars talk before, but I made it into an acronym. I hope it doesn't annoy the leadership too much. I just love acronyms. Okay, so it's the carrot, all right? And so clinical is Dr. Kruger, administrative excellence, Dr. Usef, research with Dr. Bhatnagar, advocacy with Dr. Calorie, and teaching with Dr. Cook. And so within those 5 pillars, we actually did an unusual strategic planning using AI. That is, it took those 5 areas and actually asked ChatGPT a critical question for each one. How do you get high caliber clinical program? What's the best financial administration for a Department of Medicine? How do we enhance research? How do we do health advocacy priorities and achieve excellence? And there's not enough time to go into each one of them, but there were between 12 and 16 bullet points, all of them pretty much on point. I don't have any blue for anything it said about our strategic plan. I thought it did a great job. So it's just showing you a little piece of it. On the clinical side, make sure that our clinical, we get clinical exercise by being patient-centered, by having experts and doing interdisciplinary collaboration. What's the best financial administration? We should be doing good budgeting and planning. There should be transparency, my favorite, and communication, and then having good financial oversight and controls. How about enhancing clinical research? Well, have to have a research-focused culture, provide research training and support, and prioritize research infrastructure. All of these were like talking points right out of the CREATE program, which is the Clinical Research Enhancement Awards for for excellence. And so that creating for trial excellence, that CREATE program that Dr. Bhatnagar is helping us spearhead, where we use chair funds for anyone who wants to do clinical research. We will get your project funded, and that application process should start in the next couple of months. Advocacy, it talked about access to quality healthcare, health equity and disparities, medical research funding, and on. It was right on point. How about education? How do we do medical, undergraduate and graduate medical education? Making sure we have the right objectives, the right curriculum, and developing the faculty to make this, to enhance this. So what our crew is doing is we're dividing up the strategic plan into 5 pieces. Are these the best pillars? Are these the right strategies? Ranking them in terms of not just achievability, but importance, and are the things that we would add and subtract. And so this is my open invitation to send my emails to me, or if you're in one of those 5, you're concerned about something, you have something to add in one of those 5 areas, send it to the leaders for that particular area. Okay. Before stopping, I got a couple of, when it was announced that I was going to do this, a couple of people sent me emails and said, hey, we've been doing this. So Dr. Breyer, actually, they say they've been doing AI for over 20 years. Publications in 1995 that they believe improve drug uses tremendously. And I'm glad to hear that. And then this was published just in July from Ted Smith and the Envirome, using generative AI as a tool for environmental health research. So we do have some history and track record at U of L of doing this. Now, before closing, I do want to say, you've seen how I could go and critique having, written some of the guidelines and then seeing what is said about them. And, sometimes, we got it wrong as a committee, and sometimes the AI got it wrong, and sometimes they're just not quite in sync. But there are times that we have to point out where AI is no better than the data that went into it. And this was one of them. This was published 4 days ago. I hope you all look at it. They're looking at healthcare disparities, the bias in medical or artificial intelligence. Where does the bias come from? Well, it comes from the data that made the information in the first place. And so if you're looking at hypoxia on a pulse ox and a person has dark skin, you're getting incorrect numbers. And you cannot get rid of any biases unless you have data that goes in without biases. So in summary, I would say that this is an open invitation that we want to change our culture, to be accepting of, they're not really criticisms, they're add-ons, okay? Words are important. When I see somebody, using a beta blocker for hypertension, I'll try to send you a note, okay? And hopefully you'll do exactly the same for me. Why is this so important? Medical knowledge is said to double every 73 days, and not keeping up with everything that's the latest puts both the patients and us at risk. Now, AI is great because it has the ability to instantaneously bring in massive amounts of data, and we're hoping that there will be widespread adoption of AI in cognitive specialties, not just imaging. And I can imagine getting a fair amount of EHR prompt fatigue, but to catch someone from turning someone away because they didn't fast for their lipids, it could help with that. And so we have this wealth of data. It has to be tempered by clinical experience, fact checking, which we did a lot of today, compassion and personalization. And that's what we as physicians bring to the table. And it's hard for AI to do that now. But if you saw that Joaquin Phoenix movie with Scarlett Johansson, it's a great movie. It's kind of scary because they can become more and more human in their responses. Until we're armed with this really large wealth of knowledge and AI telling us exactly what the latest is for what we're doing, and I openly admit that, yeah, I write guidelines and all this stuff, but I try not to quote anything I didn't learn in the last 18 months because it's probably not true anymore in cardiology. But hoping that we will all catch each other and help each other, have each other's back. If you see something, say something in someone's note, and let's depend on our colleagues to do the same for us. Do I really get to end with a personal point of pride? So I was at my daughter's house this weekend, and I told her what I was doing. And this happened with my other daughter when I was talking about implicit bias, and she had created a whole way of doing for a residency program in pathology at the University of Illinois, created a whole way, no pictures, no scores, in order to get rid of bias. Well, her older sister is actually CMO at a couple of hospitals. And I was said, what are you going to do, sweetheart? Pathology is going to be taken over by AI. And she said, oh, no. And so she's actually running for governor again for College of American Pathologists. And she's up in the queue for president the following year. And she set up an artificial intelligence committee. Okay. And her words were very, very striking. says, don't fight or fear artificial intelligence. And I'm going to end with that. Adopt it, adapt to it, own it, utilize it, and build for it. So, and so I will end right there, but saying that we do want to put together an AI committee for the department, and anyone who's online or in the room who wants to, please send me a note and we'll figure out who the leadership should be. I've got a couple of candidates because they emailed me about their involvement with AI. Thank you very much for doing that. And with that, just going to open it up to the rest of the time. I think we have about 5 minutes in which we can actually take your questions, and we're going to do a live demonstration of ChatGPT. Okay. All right. Thank you very much. Okay. All right. Who wants to go first? You've got one? Yes.
I'm curious. Oh,
Hi.
this was-
Did you happen to type it in? Oh, okay. I'm sorry. Yes, go ahead. Sure, go ahead.
People starting AI for fielding patient questions, like through my chart, which is like one of the most agonizing parts of medicine at this point, especially for primary care. I was just curious if you came across anything like that.
So do you want to share our look? This is what I'm envisioning. So please, that sounds crazy because you saw all the blue on the slide with that. That was not exactly right. But what we would do is actually implement it, okay? And then fact check it, and then compile it, and then publish it. That would be a fantastic help for everyone. And it may be that it's 99% and needs to be checked over every now and then. But I think you're going to find probably the same frequency that I did throughout this talk with my 8 little scenarios, that there's a fair amount of stuff that isn't exactly right, but most of it is, it would be a great time saving. It can explain things in very much lay terms, which is really important. So that would be really good. Can you send me that? I did. Okay, that'd be great. All right. So, did anyone put in anything that you can see in the chat?
There's a question, and it's really more of a question for you.
Oh, okay.
You might be able to work it into a question for AI.
Okay. Predatory access, yes, indeed. Adequate peer review. So, so it's interesting. This is Dr. Joplin. My experience with MDPI is almost the opposite. That they want their money and they want a lot of it. In terms, the question is predatory open access journals. But they actually have they publish some of my stuff, as you've seen. But again, it's a big fights with them. It's like they're fighting against their own interests. So anyway, so I think one of the things that we can do is stay with the data and keep compiling information. I think open access journals are actually an opportunity. There is one open access journal that doesn't charge the authors or the subscribers, and that's the International Journal of Disease Reversal and Prevention. Unabashed plug for that journal. All right, and Dr. Kalra, thoughts on where ownership will be when AI gets it wrong? Absolutely, and this is why it has to be checked. The buck stops with us, and I'm sure Dr. Kruger would be very interested in that question. You know, KMRRG, which she's on the board, we are at risk if we give out information without carefully looking at it. But we're planning that. Okay. Remote measurement of physical exercise be considered AI only if the monitoring was actually making prescriptions. Monitoring what people are doing and then making prescriptions, then you would consider that, you know, AI. I don't know that there's an AI program out there that does that. I know they do, but you know, they do make suggestions. There are apps for your exercise that'll guide you along. Try to not make more than 10% gain per day, that kind of thing. Okay, so no clinical questions. Does anybody want to try it? There you go.
This morning on NPR, they commented that politicians running for president in their ads have got to say whether it's generated by AI. Because
Okay.
the AI could create video of like
Yes.
Ron DeSantis at an event, and he wasn't at the event.
That is true.
So the mistakes can be horrendous. You've done a great job of showing how this can be a tool, but if you have to fact check, does it guide you in that? And do you end up doing more work at the end of the day? How do you know that what you're seeing is correct?
So yeah, you pointed out a really good point. That is, I picked out things where I was on a guideline committee where we studied it for like 2 years and reviewed the entire world's literature with a group of smart people, you know, telling me the stuff that I didn't know. So you're right. We do have to make it better, and we have to make sure that it's not using bad evidence, which there is some bad evidence out there. That's a good point. Dr. Kruger?
So you're plant-based and I'm also exercise, and I know you are too. Can you ask ChatGPT what the longevity associated with routine exercise is? I've heard it's 10 years, that it'll make you 10 years younger than your stated age if you stay physically active. There's lots to that, but we don't teach that either. And
Right.
patients get arthritis and say, I'm sorry, doc, I can't walk, and their cardiovascular risk like double. But you know, there's a lot of data. I'm curious what it's going to say.
So that's really good. So the data on plant-based diet is 15 years. The data on tennis, lifelong tennis, 17 years. Okay, so indeed. So vegan tennis players, Novak Djokovic. Okay, all right. So it generated that answer in about 8 seconds. And it talks about heart health, weight management, improved metabolism, stronger immune system, mental health, bone health, reduced chronic disease. And it did not actually give a number in terms of the length, and which is probably accurate because it really depends on what sport or what activity you're doing. But it really does talk about specific health improvement. Okay, how about it? I just changed the question. If I exercise, how much longer will I live? Okay. And still, it's not going to give us an answer. That's interesting. So that's a great question. It's not a guarantee. Life is not a guarantee. That's very, very wide. So that's interesting. That it will skirt. If you ask it emotional questions, it tends to skirt around those. If you ask it brand name questions, it skirts around those. And please don't ask it for jokes. The worst jokes I've ever seen.
Hello, Mr. Berger.
Like, why did the doctor
Hi, this
take
is
a
Dr.
red pen
Lozano.
to the clinic?
Tell me about that pain.
So he could draw blood.
Where is located?
So there are some deficits in terms of matching human intelligence, but it's a pretty
In the
good.
middle
All
of the
right,
belly.
I think we're just a little bit over. Thank you so much. Yeah. Oh, sure.
Can Shelton be Djokovic?
It's
The
a
way
crampy
Shelton
pain.
is going, he can beat anyone.
Uh-huh.
Okay.
But it's
I'm
more
actually
like
gonna
a
do that.
burn. It's more like a cramp. It's more like a cramp. And this has to do anything with the timing of eating. It's more after
Oh, yeah.
eating, before eating. You have not had breakfast, you said, and you still hurt. It's all the time.
Oh, he doesn't
all the
know who
time.
Ben
Okay.
Shelton is.
It's
Okay.
not changed
Didn't
by
know Brian
eating,
Shelton
by
either. All right.
peeing, by
Fantastic.
pooping. Nothing makes a difference. A position makes a difference. Are you better if you are laying down flat on your back?
I have an example for you.
That helps. Have you seen anything protruding, anything coming, pushing on the belly? Like, do you have like a hernia?
Essay titled The Importance of Urinalysis.
But do you notice something pushing up in your belly?
Okay, devaluación.